Hello, everyone. Welcome to Penn State CTSI BERD seminar series. The BERD stands for Biostatistics, Epidemiology and Research Design. And this seminar series in this fall semester is co-hosted by Dr. Lan Kong, Dr. Murphy, and me. We are all faculty members in the Division of Biostatistics and Bioinformatics at Penn State. And here, this is a list of the seminars to be offered in this fall semester. Let me just go through some basic logistics for this Zoom webinar. This Zoom session is being recorded automatically. And for the attendees, please mute your microphone when our speaker is giving lecture. And please feel free to submit your questions using the chat box of the Zoom during the lecture. And at the end, you may use your microphone and camera in the Q&A session. And if you registered for this webinar, you will receive email later for the slides and the recording link. And we will appreciate if you provide some feedback for us regarding the seminar. And today we are very happy to have Dr. Vida Abedi. Dr. Abedi is an associate professor in the Department of Public Health Sciences with expertise in artificial intelligence and clinical informatics. Dr. Abedi's research focuses on utilizing tools and the techniques from AI and machine learning to help bridge the gap between complex data and actionable knowledge. Dr. Abedi is excited to be working with a dedicated team of care providers and scientists to provide to find better ways to improve the health of patients around the world. Vida, you can have the screen now.
Thank you so much.
Let me.
It's my pleasure.
Yeah, welcome.
Okay. My pleasure to present at this meeting, and please, whenever there is questions that you have, don't wait. You can always add a comment in the
use the chat box.
Chat box, or if you prefer toward the end, we can also do that. So whatever is easier. Let me make sure I can have a look at the chat box as well. I'll probably look. And Jay, please, if I missed anything, you can remind me to go back to the chat box and.
Okay. Yeah, I will.
Bring the question. Thank you. Okay. So today I will be talking about the phenotype development for the EHR-based research. This is a complex problem, and I don't have all the solution. I just, give you some directions and what we have been doing, and maybe you can, some of this is going to be useful for your own research. So to just give an overview, so AI, there are many applications for AI in healthcare, and this is because there is so much data in our critical records that are waiting to be mined. So to facilitate the analysis of medical images, correlation of symptoms and biomarkers with the prognosis of the diseases, and not just correlation, but also understanding the causal effect and building causal models. Optimizing the clinical and administrative workflow, improving clinical documentation and patient outreach, and finally also improving the patient monitoring and improving the patient-physician communication and bringing the human in the loop. So even we build tools, we can focus on the preventive measures, primary prevention. We can also focus on secondary prevention, rehabilitation, but also at the acute phase. In terms of primary prevention, you can think about risk estimation, patient profiling, identifying certain gaps to improve the quality of the prevention for targeted action. In the acute phase, you can think about acute diagnosis in the ER, EMS referral, triaging, etc. In the secondary prevention, these are post-diagnosis modeling, so we can improve the treatment at the personalized level. We can also improve the outcome prediction for more targeted prevention for a recurrence or a poor outcome. And finally, there is also a lot of effort in terms of building models for application in rehab. So to improve personalized treatment and also to improve the outcome prediction. So how do we define our phenotype of interest? There is a lot of noise and a lot of challenges. That's mainly because the EHR data or administrative data that we are using is not meant for research. It's mainly meant for operation, the billing, etc. So, for example, one of my area of interest and our funding from NIH is to improve the stroke prediction model in terms of the outcome. But how do we go about defining a stroke from electronic health record? If we consult with physician, they say, yes, a stroke has ICD code, but at the same time, all the stroke patients have brain imaging. All of them will have the cholesterol lipid panel because that's the main risk factor. Majority of them will have physical therapy after they identified to have a stroke. But when we put it all together, so these numbers, this Venn diagram just basically shows that if we only identify a stroke patient with ICD code and CT images, we have a 5,000 patient, 5,110 patient. If we identify a stroke patient having MRI and CT and physiotherapy and cholesterol lipid panel, all different combination, we only have 2,766 patients. So you can see that as we add more restriction, more we define our cohort to be more precise. We are reducing the count and sample size from the electronic health record. So this also leads to a lot of issue with selection bias. So we are maybe targeting patients who have very good, quality of care, very good insurance. Maybe they've been approached by a care team that really does everything for the patient. It doesn't mean that, we want to exclude the patient who may not have physiotherapy or may not have a CT. Some patients may not have MRI because they may have a device in their brain, so they cannot, so they have contraindication for MRIs. Some patient may have a cholesterol lipid panel done at a different hospital, so it's not really available in, it's not parsed when we question the EHR data. So for many reasons, we don't want to exclude patient unnecessarily. But at the same time, if we only rely on ICD code alone, we are not capturing the whole picture and we're going to have a lot of noise. So this is kind of the rationale why we need to really do the best as we can to define our phenotype as clearly as possible without introducing selection bias and other complications. So this slide basically shows that phenotype definition, although is one of the key elements in the machine learning based models or many other trials or many other epidemiological studies, because is that one of the first step is very important to do it right, because based on that first step, everything in the pipeline is we get the database, and based on that cohort, we reduce the noise, we build models, we validate, we evaluate, we do all these things. May takes a couple of years, but if the phenotype definition is flawed, it's not as best as we could have been, and there is some biases introduced through this process, then that bias gets ripple down effect through the whole process. So there is this resource, PheKB database, is a phekb.org. You can check online. So this was built to help create electronic phenotype algorithm for transportability, and is one of the key resources when developing phenotype. It was introduced because the need for building this phenotype for GWAS and PheWAS studies across the different institutions to be able to validate these association studies. So that was the incentive, the start of it. But nonetheless, these phenotype cataloging this workflow can be used for other studies, epidemiological studies, building AI-based models. So the approach for phenotyping that was introduced was to we identify the phenotype of interest. We want to develop case and control algorithm development and refinement. There is a manual review, so to assess precision, and then deploying that algorithm at a site 1, developing genetic association test, and then replicating it at other sites or validating it at other sites. So the electronic medical record and genomics eMERGE network is what I was referring to, as well as other efforts have demonstrated that EHR data can be used to identify research-grade disease phenotype with sufficient positive and negative predictive value for a range of research questions. So these studies have required accurate, shareable, and quickly adaptable phenotype algorithm implemented in varying clinical data repositories. So moreover, research has shown that once created, these algorithms can be ported from one institution to another, and often with comparable performance. So this is a key for also AI-based models, because we don't want to have a model that only works in one place. So we want to have models that are relatively generalizable, and they can be validated across the board. So the PheKB database basically the workflow management system and learning center that supports the creation and validation and dissemination of computable algorithms. Has built-in tools specifically designed to enhance the knowledge sharing and collaboration, and basically is really designed to be adapted across different institutions. I'll give you a couple of examples on how it was used, and hopefully that you can find something useful through this resource. So it was started in 2012 and is still ongoing. So more recent collaboration are with PCORNet and Pharmacogenomic Research Network. You can also, broaden the engagement community, providing greater number of use cases. So this is the setup. So there is this pipeline, and it basically provides a knowledge base. So if we go in, we see that you can basically access validated phenotype algorithms that have been validated across multiple institutions. There is opportunity to collaborate on phenotype algorithm development and also share validated phenotype algorithm through this site. So I checked actually today, and there was 88 different entries on this site. So you can basically go and see if your phenotype of interest, there is a validated computable algorithm available. So the base comes from, we have the ICD code, CPT code. These are procedure codes. There is information on medication, and that can be leveraged to develop the algorithm. There's also labs and test results. And then in some cases, there is need for clinical notes, performing NLP, natural language processing, to extract more useful information. So these are believed to be the true cases that stem from this knowledge-based phenotyping. So as an example, I pick type 1 diabetes. I know a lot of people work with different kinds of diabetes, and then this example might be somehow relevant to a broader group here. So pseudocode for cases. So we have, diabetes. We know that it has the ICD code. We can, in this algorithm, they use the ICD code for type 1 diabetes. They also have included a table 1 for insulin, the medication code, and they excluded patients who have been prescribed type 2 diabetes medication, and they provide a table for those codes. They excluded patients with cancer, malignant cancer, and they have a table for that. They excluded patients with cystic fibrosis diagnosis with the given ICD codes, and they also excluded patients with drug-induced diabetes, and they also included some ICD codes for that. And then there is also the need to develop a control group. So in the control group, they have patients age 4 and older, and they wanted to have any diagnosis 2 or more years apart. So there is, because this is a chronic condition, so they want to have consistency in the control group. In this case, they excluded patients with diabetes diagnosis who have been prescribed insulin, and they provide, again, the table with the codes. They excluded patients who have been prescribed type 2 diabetes, again, with the code, and so forth. So, and these are the tables. So they provide all the RX norm, generic names, and their generic names and the codes, so you can easily integrate this into your code in the process of developing your algorithm. And this is, again, table 2 for medication type 2 diabetes. And they have a dictionary that they provide. So in this case, because this was developed for a genetic study, they provide what kind of genes, polygenic risk score software they used, and how it was calculated. So they have a cohort A and a cohort B, and they provide performance metrics based on different models. And they basically, the issue and limitation that they indicate is that these models were based on European population, which is something that people should be aware of. And they provide a reference. So there is also, if you can, go to this link, you can see that there is a full detail of the code that they provide, so you can use it and update it based on your specific needs or your specific subphenotype. We did a study, it was 2 papers in a row on the C. diff infection. So we first look at the variants at the MHC region that was associated with susceptibility to C. diff. It was a GWAS study using EHR data that we followed it with the integrated pipeline for C. diff prediction using, again, the EHR data. So what we did was, of course, we look at this PheKB. We started brainstorming how we would define the C. diff infection. after back and forth, we found out that this PheKB data, resource had a phenotype definition that we could use. So we integrate that image CDI phenotype definition algorithm, and that made our life much easier and more consistent with the current literature. And in the second study, when we had this, the pipeline, including the phenotype to optimize the temporal bias, we actually rely on the C. diff infection algorithm that was previously published. So I'm going to walk you through the C. diff infection pipeline, how it was done. Phenotype algorithm pseudocode. So the gold standard is that if we have a lab and we can identify this C. diff antigen or toxin test, strain A and B or A and B together. So for anyone in the age of 2 years or older. So this is the gold standard, but in some instances, this gold standard is not available. In our case, for our own EHR data, we had the lab results, so we could use this case, lab gold standard. When the lab results is not available, which happens in a lot of health systems, there is a silver standard, which is based on diagnosis. So this is in the case where patients' records include one or more diagnosis code for C. diff. And there are 3 ways that the diagnosis code combined with other information from the chart may qualify the patient as a case. So we have the diagnosis and medication, of course. So this is anyone 2 years or older with the following sequence of diagnosis code and the medication. So here is outpatient or inpatient visit, followed by one or more days of dispensed medication for treating C. diff, followed by inpatient or outpatient visit with C. diff, diagnosis of C. diff. There is also the diagnosis code for C. diff is provided, and the medication to treat C. diff are also provided. Diagnosis and progress notes. So in some cases, if we don't have the labs, we can also look at the clinical notes to identify keywords that may be improving our phenotype definition. And I know that accessing to clinical notes can be very challenging, but that's something that is a work in progress. So some institutions have easier access to notes than others. Again, progress notes mention only, so in this case, it's a silver standard where the labs are not available, so you can have 2 or more encounters on separate calendar days with the affirmative mention of C. diff in the progress notes. And then there is also exclusion criteria that exclude patients that have any diagnosis code of bone marrow cancer in a 2-year period prior to C. diff index, or the 7-day prior following the C. diff index, and the patient receiving cancer chemotherapy in the 180 days prior to the C. diff infection. Although these numbers sometimes look arbitrary, since they have been validated and there is a consensus on this decision making, it's easier to compare results when you build something that is based on something that is published. And for control group, you want to also have a control group because for any of such studies, it's important to have a comparison to be able to identify, proper metric and proper performance measures. So I don't want to go through the details here, but at the end of the day, I just wanted to show you that there is very detailed algorithm and very detailed codes that you can use. So in this case, there's a lot of covariates that they provide, so time, medication, especially for C. diff, because it needs a lot of combination of medication and antibiotics cocktail. So it's very helpful to have this information provided. And also the duration of the medication is important. So we end up with something like this. So this is also provided in the resources of the CDIF algorithm. So where we start, where we are, if we go with the gold standard, if we go with silver standards, and how do we find case and control for comparison. And then they provide all the different appendix for medication, for different disease codes, and so forth. So any questions so far before I go to the next? Let me see where is my? Okay, so let me leave the chat here so I have a look. So there is also another resource or another way to develop a phenotype is through Phecodes. It's done for research with EHR data. So Phecode represents one strategy for defining phenotype using EHR data based on ICD code. So this is a more high throughput for larger scale studies. Phecodes originally was developed to conduct PheWAS to scan phenotypic association with common genetic variants and have been used to support a wide range of EHR-based phenotyping methods, including, the phenotype risk score. So this is basically based on grouping international classification of disease codes into useful phenotype. So you can check the website here to learn more, but essentially is there is, when you go, there is different versions. So in this case, the latest version was 1.2, included 1,800 Phecodes for different diagnoses and symptoms and findings. So Phecodes are great for larger scale studies that you want to have understand, overall type 2 diabetes. But when you go to very subspecialized narrow phenotype, this may be too kind of wide or too abstract. So it really depends the level of abstraction. So now the question is, what if there is no entry or there is no validated phenotype for the disease of your interest, right? So this happens all the time. So I'm going to show you a couple of examples. I go deeper in one. Predicting a stroke in ED. So this is basically, I'll probably explain more in detail. But essentially, when we define a stroke, we want to have the ICD code as the base, but we also want to understand the length of hospitalization. Is there any imaging? And also the control. Control is very hard when we talk about ED visit because, control is supposed to be healthy in many situations, not always, but who is healthy and goes to ED? So it's kind of a daunting question. So in this case, we can look at ED visit with no stroke, but also exclude patient who had trauma or some kind of accident or some kind of, something that was obviously not a stroke. So there are different levels of control that we can build. Another example is septic shock in patient with, so how can we predict septic shock in patient with sepsis? So the issue or the challenge with this sepsis or septic shock is that the definition of the phenotype is always changing as we learn more, especially since sepsis is a very complex and heterogeneous condition. Control can be sepsis patient not progressing to septic shock. And because another challenge with this definition or with this condition is that how fast this progression is. So, it could be in a matter of hours or minutes. And building those kind of algorithms to be so sophisticated at almost a real time by itself is a challenging task. We can build prediction models for post-stroke mortality or 30-day readmission. So these are patients who all have a stroke, but in terms of their outcome, we can look at 30-day readmission. So especially when we have a health system that has a competing health system not very far, we may miss some of those readmitted cases. So we need to be really careful how do we build our algorithm and not to miss any important cases. So one of our funded studies is to build machine learning-based prediction of 1-year mortality and recurrence after ischemic stroke using enriched EHR data. And how do we define a stroke is, you know, I mentioned it earlier too, is challenging because we want to have a very precise definition, but we also want to make sure that we don't have a lot of missingness, we don't have a lot of sparsity, and we don't have a lot of selection bias as much as possible. So it's kind of building that balanced cohort is not easy. So what we start doing is that we identify ICD code. We filter based on where the patient goes. So if it's an emergency visit, if it's an inpatient, so there is that filtering. We also want to make sure that these patients don't have the ICD code and just leave right away. They at least one night is, you know, in the hospital. This is to reduce the noise with respect to if patient comes in, they have a migraine or something, they feel dizzy. So the provider may add a tentative ICD code for a stroke, but based on a bit more digging, a bit more evaluation, they identify that this is not a stroke, and they discharge a patient to go home with some cocktail of medication for dizziness or headache. So a lot of time, the ICD code for a stroke is not removed from the chart. So if we don't have additional exclusion criteria, we may have a lot more patient than we would want to have with a lot of noise. When we talk to physicians, they tell us that, you know, all these stroke patients, they will have CT, MRI, all these brain images, and they will also have opportunity to benefit from physiotherapy, rehab, but they will also, all of them have cholesterol and lipid, without which they would not really, you know, they would do the blood work upfront, especially since this is not very expensive and, you know, at the base, they want to know if the patient has cholesterol. Okay. So going back to this Venn diagram, so when we look at the intersection between different variables, MRI, CT, physiotherapy, and cholesterol, we see that, you know, each of these combinations, they give us a snapshot. And the numbers really show us that there is no one way to define a stroke. So we may have to compromise and we may have to look deeper. So what we did to look deeper is that we work with the stroke coordinators and the stroke team here at Penn State to have you know, counts of patients in their stroke registry, which is manually curated for quality improvement. So if you see in this line, so there is two lines in each subplot, there is two lines. One of them is a black line and one of it is a colorful line. So the black line is the number of stroke patients per month from 2016 to 2023, to the end of last year. So these are the total count of monthly stroke patients. So when we put that and compare it with the different definition, we can see what is the definition that mostly correlate with the stroke registry counts. So for example, in the red, these are all the patients who have ICD code. That's it, just ICD code. So if we only include ICD code compared with the stroke registry, we are seeing that we are over-representing. So we have a lot more, at least 20–30% more cases identified that may not be in the stroke registry. For example, in the third subplot, the green one, these are ICD code in addition to imaging and lipid or rehab. So we have this combination and with the condition, so lipid profile or rehabilitation. We can see that we are getting closer and so forth. And sometimes you can see that it's not always the same. So in the last panel, we have the ICD code plus CT and the lipid profile. So initially in the early years, 2016 to 2018, roughly, we can see that this definition was not capturing all the stroke patients, as the gray line is below the black line. But as we passed this threshold in 2018, in June of 2018, these are more closely replicated, which means that the coding was not probably done properly, or it could be that either the CT or lipid profile were not capturing all the patients, but after a certain point, we have a better coding or better referral system that we are basically getting very close to the stroke registry. So now the question is, why don't we just use a stroke registry for our research, and why bother doing all these things to have a computable phenotype? The quick answer is that we want to build the phenotype definition that we can automatically, even in the future, identify a stroke patient, but also a stroke registry doesn't have all the variables that we are interested in. They have variables that is interested for their own quality improvement purposes. But what we want to work with is the PCORI path network and identify a computable phenotype that we can automate and also be able to replicate across the different hospitals. So building external validation. So of course, one center can be biased. We can have very accurate, rehabilitation program, or we can have a very good brain imaging resources. So we want to make sure that when we test this algorithm, we can validate it across different centers. So this is a multi-center studies that we have Geisinger and Johns Hopkins part of the team. So we are basically, and even Geisinger and Penn State, we have multiple hospitals. So these are two of the centers, two of the hospitals that we replicate the phenotype algorithm that we develop here at Penn State. So this study basically demonstrates the potential of EHR in defining and standardizing ischemic stroke phenotype. So the definition of combining MRI and lipid profile shows the strongest correlation across the multiple centers. But also we know that we have the temporal variation in the stroke identification. And there is always a need to adaptively evaluate our phenotyping strategy to accommodate the evolving clinical practices. So the validation of these findings across different hospitals enhance the generalizability of this tool, and we are basically running the final validation test across multiple additional centers within our group to make sure that these are truly generalizable, and if there is potential biases across the board, we can identify those. So this study also highlights the value of working closely with the clinical team when available, and really asking the hard question, asking very specific question from, in this case, we work very closely with stroke navigators and stroke team to, access these counts, and we don't really have to have the identifiable information. For us, it was sufficient to know the average number of unique patients they had to validate our phenotype. And to wrap it up, is basically we want to make sure that the future of healthcare, how we envision it in terms of clinical informatics, AI, is not just AI and big data, but also there is a human connection to it, and it's not enough to provide faster, better care. But we want to leverage a technology and develop something that is fair and not biased to a specific group of population. So we still have a long way to go, and this is the team. So I get a lot of credit. I don't want to emphasize the team, especially Ramin Zand, vascular neurologist, our stroke doctor, Ali Reza Faisat, who generated the nice figures you saw in the temporal patterns. Ajit Vermuri, also a data scientist in the team. Sasam Bahrami, our research project manager, and truly a collaborative team. A big thank to Dr. Wang. Jiangli work on the CDIF project, Wenki work on the Geisinger EHR data. Dr. Clemens Shermer work also on the stroke registry at Geisinger to help us identify the stroke registry counts at Geisinger. Anne-Marie, also from Geisinger, Harold Lehman from Hopkins, and Mona Bertom also from Hopkins, are collaborators. And we have a lot of student support. Deb, a new student from DRPH program, and Olan, also a DRPH program student. Thank you. I think we have 15 minutes or so for questions. So
Thank you very much, Vida. Thank you for this nice talk on this very interesting and also very important topics about the electronic medical data. Yeah, I have, like myself, have worked with the EHR data before. I know that for the EHR data, it's usually very massive and with lots of information, multi-dimensional, and also it's usually very messy to deal with those messy data. Like one quick question of mine is that, like, when you talk about the phenotype, is this phenotype usually like a binary, like what you mentioned, the case and control?
Oftentimes in most of the studies, I see it's a binary.
Binary.
So you define case, but sometimes, for example, when we develop a stroke in ED, we have a case which was very defined, a stroke patient in ED, but in the control, we had multiple control patients who were more closer, similar to a stroke patient with some vision, problem or some migraine. So they were still controlled, but the condition was a mimic kind of to a stroke. So we developed multiple control at different degree of distance from the case to show how robust our algorithm is at identifying, true cases or not.
All right. I myself still have a couple questions that I want to see, like, for our audience. If you have any question, please feel free to use your microphone and video camera to talk to our speakers.
Yeah, stop sharing so we can see better each other.
Yeah. Or you can post if it's more convenient for you. You can post on the chat box. Any questions? Oh, Terry.
Hi, Vida. Thanks.
Hi.
Very nice talk. It's interesting. I've worked with ICU doctors, and they've tried to define things like, I don't know, certain lung cancer conditions. And it's a sort of algorithm like you've described, where they do a certain number of tests, and if some tests are negative and others are positive, they kind of go through, and in the end they say, yes, this person has the condition. And usually there's no true false negative, What interested me about your stroke example was, those of us who are not clinical, we tend to grant doctors these godlike powers, right, of divination. And so if a doctor says you have a stroke, we say, oh, okay, I must have a stroke. But what you've shown us is you showed us 4 different, completely different criteria. And my understanding was that you really define the stroke as those people who are the and condition. They satisfy all 4 conditions. So is that generally the case with these other conditions too, that the algorithms, you have, say, 3 or 4 different media that are each measuring different things, and you look for the intersection of multiple criteria to come up with that binary diagnostic?
So that's a great question. Yes. And when you talk to different physicians with different level of expertise or different, the first-hand experience, if there is ICU or there is hospitalists, so they see things as slightly different, and the priority of what is the most important things can vary. So it's good to talk to as many people and have kind of all the elements checked. But what we found that, of course, we can have a set number of conditions with the and, but then we should have some flexibility. So in the last bucket where we had the imaging, when we had the rehab or lipid panel, we initially wanted to have everything. When we talked to the collaborator at Hopkins, they say half of our population is underserved. We are not going to do MRI on every patient. So remove your MRI condition for us. So it's not going to work. So that led us to kind of explore in a data-driven fashion to see what if we have different combination of these things. Because, Penn State, yes, we do MRI for 99% of the cases, but, at Hopkins in Baltimore area, maybe just do CT, and maybe the load is much higher, so they cannot, in practical term, be very comprehensive in how they identify their cases.
Thank you very much.
Yeah, thank you, Vida. There's one question posted in the chat box if you want to take a look.
Okay. So identifying what are the differences between using AI and traditional statistical modeling for phenotyping. So the process of phenotyping, if you don't really need the AI to do it, is more kind of a rule-based process. It's a kind of procedural, a lot of experimentation, a lot of back and forth. What the AI will come is at the end. Once we have a clear definition how to identify our cases, our control, then we can have a labeled data based on which we can build a prediction model or classification model. In that case, it could be a statistical or AI. It doesn't matter. We just want to have a clear playground to develop those models. I don't know if I answered the question.
Any other question from our audience?
Hi, Winky.
Venki?
Hi, Vida. I just wanted to echo what Dr. Murphy was highlighted, and I think it's a very important point. Healthcare data, including EHR, claims, and whatever. The most important challenges is the false negative. So, and I don't know, actually there is a good solution to help the false negative things. And false negative maybe because that the patients who are seeking care in multiple institutions, and some of the information may reside in Pittsburgh or Hopkins or Ohio, who knows? And we would not know that. So, so when we say this individual does not have stroke, well, that is based on our information. But there are some other information out there that may say otherwise. So I think that Dr. Murphy's point is it's very important. And there are another case that may have a false negative, and that is that for those individual and population that did not come to the healthcare system at all, right? So in some way, when we identify the case and control, that we also wanted to acknowledge that these are the individual that come to seek care. So I believe that it's a very important, and I don't know actually there is a good methods or approach to manage that. But anyway, that's just a quick comment.
Thank you so much.
Yeah, thank you, Wan-Ki. Vida, there's more questions
Yes.
posted.
So the approach, something like metabolic syndrome that has multiple phenotype, I guess it goes back to the research question that you have in mind. So if your research question is to look at the one of these subphenotype and compare it with something else, then you can really narrow it down to that specific subphenotype. Just goes back to, what actually the phenotype that we used here, I used here meant to clinical understanding or sign and symptoms for, you could, even a stroke, it has ischemic stroke, it has the hemorrhagic stroke. So in this case, we were talking about ischemic stroke. So I guess that's, I don't know if that was the question. So the clustering method to develop a phenotype. So that's a interesting question. So there is a lot of literature on developing clustering to separate different patients when there is a lot of heterogeneity. The challenge with that, I don't say it's the wrong thing to do, it's harder, is the validation process. So how do you go back and identify this cluster, and how do you validate that these are together, what is the clinical indication to show that these are strong enough, this specific cluster that you identify, they have clinical meaning or underpinning in them. So the validation is a challenge when we talk about clustering.
So Vida, I think that a couple of your slides really highlighted very, very important things, especially for multi-site study. And that is, what if the best strategy for computer phenotyping differ from site to site? So would we, as a researcher, develop a protocol depends on the best option per site, per local situation, or that in a more traditional way of doing the multi-site study, that we are taking a pen and to really consolidate that to finding a middle ground, but it's a uniform middle ground. What would your thought about that?
I mean, the best example is when we start talking to our colleagues at Hopkins. We even published this as a stroke in a stroke journal. We have our understanding of how a stroke is treated at Geisinger, at Penn State. We have a solid pipeline that our stroke doctors are using to kind of care for these patients. And we are basically talking to our colleagues at Hopkins, and they come up to us say, no, we cannot do this kind of things because we don't have the resources to, give MRI to every patient. So that was, even for something that I worked with like for 5-6 years, that was a kind of a wake-up call. External validation is truly important, even if I know say multiple times, but even if a phenotype that you're very comfortable with, you still need to talk to people from other centers, different demographic, to see how exactly they are dealing with those patients.
Nice. Yeah, I think Wan-Ki's question was exactly mine. Like, when you try to keep the balance, I think you have a very nice slide showing we have to keep a balance between like the clear definition of the phenotype, and also the other side is reducing the missingness, the increase the sample size, and reducing the bias. So like when you find one strategy for one institute, and it's yeah, you actually mentioned using the Hopkins example that it is possible that for the other institute, this same strategy may not be applicable, right? But when you try to combine the result, then probably have to find some common ground, right?
So so if we were going to use the MRI condition for Hopkins, they would have a lot of they would have a lot of selection bias.
Yeah.
Because they would really, it is not like the patient we identify through this process would not be stroke. They would be stroke, but we would miss a lot of non-MRI, but a stroke patient. But at the same time, if we are relaxing the lipid panel condition, sorry. So in those situations, if we have additional labs, like let's say we have A1C as additional constraint, we would have a lot of missingness in that variables naturally. So, sorry.
Yeah.
So Jay, I'll give you one small example. It's a funny example, but it's not so funny, really. That's seriously, that's in research that I took it not so lightly. So for example, in one of the phenotype that we are investigating, and we have tried all the things that we can find anywhere and experimented it. But in the end, you know what works best for our patient to identify that rare disease is by who the providers are or the specialized clinics that this patient go to. But obviously, this is very local, right? So the question that to us, and I'll get back to Dr. Murphy of false negative and your question about the, all this local decision and local phenotype. So the decision is that how do we make decisions for something like this? And I think that I really look forward to Dr. Abedi's research move forward and give us more lesson on this front.
It's a complicated word.
Yeah. The more we think we know, the more we don't know.
Yeah. See if our audience have more questions. Let me see what time it is. Oh, it's almost the 2. Any last minute question? Right. I think it's about time. We have to end this seminar. Thank you very much again, Vida.